Welcome, everyone, to the TriClip TEER Therapy Foundations for Valve Coordinators webinar. I'm Dr. Nadeem Gulu. I'm the Senior Medical Director for Structural Heart here at Abbott, and we're very excited to have all of you join us for this very informative evening. We've got two of our leading valve coordinators in the country joining us who will be running the didactic program. I'll start by saying that a successful structural heart program cannot be built without a capable valve coordinator, and that bears repeating. A successful structural program cannot be built without a capable nurse practitioner. These are the folks that actually spend more time with the patient, both before the procedure, during the evaluation, oftentimes during the hospitalization, and certainly afterwards. The coordinators spend more time and have more of an intimate relationship with the patient than even the physician. I say this having directed a very large structural heart program myself, and I can tell you that it certainly would not have been as successful as it was without my very gifted valve coordinators. And we're fortunate to have today not just capable valve coordinators, but two vaunted valve coordinators who are leading programs across the country. First, and just in no particular order, first we have Dr. Lindsay Hart. She has a doctorate in nurse practitioner education, and she presently works at St. Francis Hospital. Lindsay obtained her nursing degree from the University of Scranton in 2010. And worked in the telemetry unit and the cardiothoracic intensive care unit before obtaining her adult gerontology nurse practitioner degree from Malloy University in 2016, and then her Doctor of Nurse Practice degree from Duke University in 2020. Lindsay was the lead structural heart nurse practitioner coordinator at Maimonides Medical Center in Brooklyn, New York for over 5 years before she joined St. Francis Hospital, which we all know is one of the leading institutions for heart valve disease in the country. Lindsay joined St. Francis Heart Valve team in 2023. This site, St. Francis, became the 10th site in the country and the first in New York to achieve ACC Valve Center accreditation. And for the past 3 years, the institution of St. Francis achieved 3 stars for clinical outcomes from the TVT Registry. So again, we're very fortunate to have Lindsay here today. Sarah Kennedy is a nurse practitioner and acute nurse. She's a nurse practitioner and valve clinic coordinator at Centera Hospital in Norfolk, Virginia, a place that's near and dear to my heart, having spent some time there myself. She has a background in critical care, interventional cardiology, and cardiothoracic surgery. The Centera Heart Valve and Structural Disease Center is the only program in southeastern Virginia and northeastern North Carolina focused on diagnosing and treating heart valve disease and structural heart abnormalities. The center offers the most innovative heart valve repair program options available, including the newest generation of valves that physicians implant through minimally invasive procedures. The center was first in the region to offer these advanced transcatheter treatments. These include TAVR, MitraClip, mitral valve replacement done transseptally and also transapically, and also left atrial appendage closure devices for atrial fibrillation. Again, we're very fortunate to have both Lindsay and Sarah here today. Sarah, you're going to go first. Thank you.
Yeah, thank you. All right. So thank you so much. I'm so happy to be here with you guys tonight. Thank you for taking the time to join us and talk about tricuspid regurgitation. So we're going to start just talking about the prevalence of TR, this valve pathology. So many of us work in structural heart clinics, and we're very used to treating aortic stenosis and mitral regurgitation. And tricuspid regurgitation has been this valve pathology that's been there, but historically under-recognized and absolutely undertreated. And when we think back of why that is, it basically comes down to there really wasn't a good option for addressing it and fixing it. So looking at this graphic, I was actually shocked that tricuspid regurgitation is almost twice as prevalent as aortic stenosis. And when you look down at the percentage treated, it's 0.6% treated. But with every pathology, we have to figure out a pathway. How do we get these patients in the door? How do we get them to the end result of a nice clip or valve replacement? So when patients come into our clinic and we have an echocardiogram that says the patient has moderate or severe tricuspid regurgitation, what do those patients complain of? Well, sometimes they can be a little bit subtle of symptoms. Patients will say, I have fatigue. And then as that TR develops and that right heart starts to expand or more dysfunction occurs, you have more significant symptoms such as shortness of breath, swelling in the legs, abdominal fullness, ascites. Sometimes these patients say they don't have an appetite, all of that fluid buildup in the gut. You'll see cardiac cachexia. These patients aren't eating. They become thin with these big bellies. And many patients will just say, I'm getting older. I'm not eating as much. I don't feel like I want to do as much. But really, it's their tricuspid regurgitation that could be causing some of these symptoms. But what can we do about it? So before we had an option of a less invasive transcatheter repair or replacement, really medicine was all we had for patients who weren't candidates for surgery. So this graphic does a really nice job of laying out how effective that medicine is in reducing tricuspid regurgitation. When you look at the bar graph on the left, you can see at the baseline, that was all of the severe tricuspid regurgitation at baseline. At 30 days on medical management alone, so basically diuretics, you can see there was really only a 5% change from severe or torrential to moderate tricuspid regurgitation. And at that point, if you saw that one patient out of 100 and you said, hey, they actually look a little bit better, let's just continue this pathway and see what they look like at a year. The truth is, just because they had a little bit of improvement there, when you look at that 1 year data, still only 5% had an improvement with medical management. So that tells us 95% of those patients showed no improvement with medical management alone. That tells us medicines do not work for this problem. We're fixing the echo, and that's fantastic when we see reduction in TR on an echo, but what does that mean for the patient? And when you look at this graphic to the right, you can see that not only did we improve their tricuspid regurgitation, we're also looking at improving their quality of life. Patients that had a 2+ improvement in their TR or reduction from severe to moderate or less showed a mean of 18-point improvement or reported improvement in their symptoms and quality of life, according to the KCCQ survey. So medical management is one option. And historically, the other option we had was tricuspid valve surgery. And most of us are not putting patients through open heart surgery for a tricuspid valve, unless it's endocarditis or something congenital or a reason that we have to open their chest. And when you look at those statistics, the first thing that pointed out when I saw this slide was we know the prevalence of TR is 1.6 million. When you look at the STS database of the actual number of tricuspid valve surgeries during a 10-year period, 2011 to 2020, only 6,500 were in that database. And then you look at the age of 65. So that's a pretty young number, pretty young patient undergoing cardiac surgery. The operative mortality of that group was about 7%, so not low risk. And then we look at some of the complications that are common with tricuspid valve surgery. And that makes sense because when you're putting in a valve into that right side of the heart, it's a lower flow area. So those patients may need anticoagulation. There's a higher risk of bleeding. The right side of the heart is a lot more finicky, a little bit less robust than the left side of the heart. So you're balancing that fluid and those diuretics. And sometimes those patients develop acute kidney injury. Sometimes that right heart kind of punks out and doesn't give you the output that you need. So dialysis is not uncommon. And the length of stay was 8 days for that patient population. So that's not an in and out procedure. Now, that being said, the surgical mortality and morbidity for surgical repair was a little bit more favorable. So we're not going to do medicines. We're trying not to do surgery. So let's talk about TriClip. So TriClip feels newer to us. To a lot of our structural heart centers, this is kind of a newer and exciting time. Like I said, we're very good at aortic stenosis, very good at mitral regurgitation, but TR was something that was historically a little bit ignored. When you look at kind of the history, MitraClip was started in 2013, so it's not a new therapy overall. Clipping valves is not a new concept. Triluminate, 2017. And then when you look at 2020, you can see that TriClip was approved in Canada and Europe back in 2020. So although TriClip is just approved in the US last year, they've been clipping valves, and we have data to support the safety and the efficacy of clipping tricuspid valves for almost 5 years. And the delivery system, just so you can be familiar when you talk to patients about this, is very similar to what you see when you do a MitraClip. You can see the handle back here. You see multiple knobs, and these knobs are for flexion and extension of the catheters. They can help move the device lateral and septal just to kind of line up with the valve and get a really nice result when you're aiming for that tricuspid valve. It's a 25-French delivery system, so it is a big catheter, and the typical entry point is that right femoral vein. It is important to say that the TriClip system looks like the MitraClip system, but it is specifically designed for the right side of the heart. So it's not a system that they're designed for the left and moving over to the right. It is designed for the right side of the heart. And there's a broad range of clip sizes, just like there is for MitraClip. So you can see that when you have a valve, and not all valves are created equal, everyone's valve looks a little bit different. And there's different kind of stepwise approaches you can take to getting a nice result when you clip a tricuspid valve. The implanters are going to look and make decisions based on that patient's specific anatomy. You can have clips that are shorter, and you can have clips that are longer. You can have clips that are narrow, and you can have clips that are wide. And when the implanter or the clinician and your TriClip rep look at your echo data and your TEE, they're going to make decisions on an approach to best get a result that has a reduction in your TR. So it may be one clip, and maybe 3 clips, but it's basically a stepwise approach to getting a nice result or reduction in your TR. So let's look at the data. So when I look at data, I always want to know, is it safe? Is it effective? Does it make patients feel better? Okay. And there's data here from the Triluminate trial, BRIGHT, and Triluminate pivotal study. And when you look across the board for all 3, you can see there's almost 100% implant success for all 3 trials. You can see 80% reduction in TR from severe or torrential to moderate or less. And we saw from that earlier graphic, just getting it to moderate or less had a mean 18-point improvement in the KCCQ. So it doesn't have to be a perfect result when you clip a valve, which is good to know. And then class 1 or 2 heart failure, 70 to 80% went from usually class 3 to 4 heart failure to class 1 to 2. And you can kind of see on the small text under those numbers that the comparison of 19 to 70% from 24% to 82%. So huge improvements in quality of life. And we're going to dive deeper into that in a little bit. It's a safe procedure, low risk of major adverse events like stroke, death, major cardiac problems, improvement of quality of life, and improvement in the actual heart itself and the RV size. So when we look at this, is it safe? 98% free from major adverse effects at 1 month. Is it effective? 90% reduction in TR to moderate or less. And then does it help patients feel better? And we're going to talk a little bit more about that. So here's another slide that kind of dives into the efficacy or how effective the TriClip is. And when you're looking at this graphic, you can see at baseline, all that red is your severe and your torrential TR. The next is your 30-day, and it compares the device arm to that control arm that we looked at earlier, that's medication alone. And with the Triluminate study, it basically randomized you to getting the device, the TriClip, or medicines alone, which we know are putting you on diuretics and kind of watching. At 30 days, significant improvement in the TR and a big change, or a big difference, I should say, between the device arm and the control arm. Those numbers stayed at 1 year, which is incredible, showing an 89% reduction to moderate or less TR at 1 year. So yes, Triluminate or TriClip works. And then we say, yes, it works, but does it actually help patients? Do patients feel better? So this is a comparison of KCCQ scores, and the KCCQ we're probably all pretty familiar with as coordinators, but it's that survey or that interview questionnaire that patients take when they have their initial consultation, and it asks about swelling in their legs, can you sleep at night, how often does your shortness of breath affect your everyday? And you can see if a 5-point improvement in a KCCQ is considered significant, a 15-point improvement at 1 year is huge. And 50% of patients reported a 15-point improvement or higher at that 1 year mark. So yeah, patients are feeling better with TriClip. But not only are they feeling better, are they staying out of the hospital? Because this patient population, we worry about recurrent fluid accumulation. They're bouncing in and out of the hospital. No matter what diuretics we give them, we're either causing acute kidney injuries because we can't keep the fluid off, or they're back in the hospital because the fluid's built back up. So then we look at, does TriClip keep patients out of the hospital, which is important to quality of life. And so this is a comparison between early phase implantation and later phase implantation. And when I think about this, it makes total sense, because the tricuspid valve is complex. It does take practice to get a nice result. And it does take coordinators and clinicians kind of time to figure the nuance of how to get these patients through safely through the pathway. And so what we found is when we first started clipping valves, we did okay. We didn't do any worse than medicines alone, keeping patients out of the hospital and, frequent heart failure hospitalizations. But then later, as implanters got better at it, and we figured out that patients need to be diuresed, we need stable diuretic regimens, that the patient needs to be euvolemic so they get a nice result on their TriClip day. Those patients had a significant reduction in heart failure hospitalizations compared to medical therapy alone. So what does that mean? What are the considerations that we have to think about when we talk to patients, when they ask about expectations for the procedure? How does this affect me? What can I expect? What are my complications with the procedure? Is it safe? So, and I am going to compare a little bit with the TriClip with the tricuspid valve replacement, even though this is a talk about TriClip today, because it affects patient selection. So when you're doing a TriClip, it's a pretty safe procedure. The patients are in the hospital for 1 day. 98% go home the next day. Low risk of any kind of conduction abnormalities or needing a pacemaker. We don't send our patients home on monitors after a TriClip. 15-point improvement in the KCCQ, which we talked about, and low risk of major bleeding complications, less than 5%, even though it's a big catheter. It's a 25 French catheter in the leg. Now, I say this just as a comparison because there's also transcatheter tricuspid valve replacement. And I do believe there is a place for TTVR, and there is a subset of patient population that benefits from this. All anatomy is not clippable. But when you talk to patients and you start to work them up and you say, I'm going to get your TEE and we're going to make decisions on how we fix this tricuspid valve, you're not only looking at that TEE, you're looking at the whole person. And you need to decide at that time, there is a difference in the safety profile or the considerations of post-hospitalization regarding that patient care. The patient's going to have a little bit more time in the hospital. There is a higher risk of pacemaker. So when you talk about TTVR, it's a bigger piece of equipment in the heart, okay? So there's a little bit higher risk of conduction abnormalities. So you need to talk to patients about the pacemaker risk related to that. The other thing that I kind of look at when I'm talking about TriClip versus TTVR is the patient a candidate for anticoagulation? There is a higher bleeding risk with tricuspid valve replacement because those patients are put on blood thinners. Just like surgical TTVR, it's a lower flow area on the right side of the heart, so it does require anticoagulation. So we looked at that data, and then you look at 1 year when you talk to patients, still a little bit of a bleeding risk at 15% because those patients are on blood thinners, 28%, so a little bit higher risk. A couple more patients did need pacemakers after that 30-day period. But you also have to think about thrombosis because it is a valve placed in a lower flow side of the heart. So that's something we have to think about when you have patient selection. And again, there are patients that are absolutely good candidates for TTVR, but when you're looking at these patients as coordinators and we're having these conversations about expectations and how long you're going to be in the hospital and what to expect after procedure, it's nice to kind of know the comparing data. So let's shift gears and let's talk a little bit about the patient journey. So kudos to Abbott. The first step of any of this is developing that relationship with your patient as an empowered partner. These patients have to build trust with you and with your team so that the conversations can be open and honest. With tricuspid regurgitation specifically, I feel like this is important. A lot of the time when I meet someone with AS and MR, we're moving forward with the workup. I'll say when I meet someone with tricuspid regurgitation, because sometimes those symptoms are a little bit more subtle, and I'm introducing the idea of this therapy, sometimes I'm going to see them back in 4 to 6 weeks with the caveat that if you start to feel worse, you call me before. Building that kind of trust that says, hey, I want to do the right thing for you, but I also need you to tell me if you're doing poorly is huge. This is a nice example of shared decision-making with your patient. Starts with the initial, scheduling the appointment, providing education, making sure that the patient has the literacy to understand the information, and then giving them a chance to absorb it, bring it back to you, where you can give your expertise, but ultimately it's a shared decision amongst both team members. And then clinic flow, which we're going to continue to talk about. Many patients are referred to the valve clinic. Every structural heart clinic does this a little bit differently. Some coordinators screen the consultations ahead of time and then get their workflow, their imaging, and schedule them for the consult. Some see them in consult first and then schedule their testing. Whichever pathway works for you, this is an example of one that could work if you haven't developed yours yet. One point I do want to kind of point out on this workflow is the importance of submitting that imaging to your TriClip rep for review. Because this is a complex valve pathology, the TriClip rep is going to be the expert at looking at that echo and looking at that TEE and giving advice on how to address it. So anytime we have a severe tricuspid regurgitation, we're deciding between repair or replacement, and we want to make the best decision for the patient and get a good result, we're always including our TriClip representative to look at that TEE and give their opinion on what they think would be a good result or what could be. So this is an example. Before I hand it over to Lindsay, I just want to give you an example of what we do at Sentara. In our practice, we get our initial consultation. If they're not on a good diuretic regimen, we'll usually put them on that then. If they're on Lasix and they're not getting enough fluid off, we might change them to Bumex or torsemide we'll likely add aldactone and kind of get those meds optimized as much as possible. We'll schedule them for the right heart cath and transesophageal echo. This is where it gets a little tricky. For the TriClip procedure, you want the patient as euvolemic as possible because you want that valve to be together as much as possible. Tricuspid valve, dynamic valve, they're fluid overloaded, it stretches and it's farther apart, making that coaptation gap more difficult. So we get the right heart cath, confirm that they're euvolemic, and if they are, we'll get the TEE that same day. If not, we're going to have to adjust their diuretics. We may admit them, start them on IV diuretics, keep them for a few days so we can safely diurese them, watching their kidney function, watch their electrolytes, and get their TEE as an inpatient. If we can do it outpatient safely, we'll do it that way too. Once we get their imaging, have the right heart cath, look at their PA pressures, then we involve all of our other teams. Do they have concomitant MR? And we'll maybe address the MR first. Do they have evidence of RV dysfunction? Do they have significant pulmonary hypertension? Do we need to engage heart failure now? Do they have a lead across the valve? Do we need to engage EP? That's where we usually invite all of our other subspecialties to kind of help us with this decision making. And then it comes down to the heart team discussion where we all sit together and make basically decisions or make recommendations based on our expertise. After we have that heart team discussion, we call the patient, we talk to them about our recommendations, see how they're feeling, and then they can weigh in on what they would like to do moving forward.
Thank you so much, Sarah. That was a great presentation. Thank you for sharing all your insights. We do have a couple of questions before we move on to Lindsay. Let's see. The first one is, do you have patients seen by heart failure doctors at your institution as part of the evaluation?
So we don't always have them seen at that initial consultation. We do have them weigh in. They're always part of our heart team discussion. And if they're not, because GDMT is limited in the tricuspid regurgitation space, it's usually diuretics alone. So we'll do everything we can to get them on good GDMT, get them on diuretics. And we do have a heart failure specialist weigh in, but not always seen by the heart failure specialist.
Okay, we'll give one more question to you, then we want to make sure we move on to Lindsay because I want to make sure she has time for all of her slides. Can you tell us about how many patients you're pre-admitting for fine-tuning of their heart failure procedure?
Yeah,
for heart failure management before the procedure?
That's a great question. I would say when we first started doing it, we were probably admitting 75%. The patients were coming to us decompensated. We weren't sure exactly how to do this. I say now that we've had it fine-tuned and we feel comfortable with changing around their diuretics and their expected response, I would say we probably admit maybe 20%.
Okay, great. Thank you. So I in the interest of time, I think we're going to move on to Lindsay, and she's going to talk to us about the patient journey. And then we'll come back to some questions at the end so that we can try to get you guys ending on time this evening. Lindsay, go for it.
Sure. Thanks so much. Thank you, Sarah, for introducing us into this patient journey portion. So here at St. Francis, I kind of laid it out that we have two kind of different experiences, one on the front end with the patient. The patient calls us, or we get a call from the referring physician to make an appointment. We fill out an intake form. So anybody who gets the call can fill out this intake form. It's pretty simple, has some medical history on it, some simple information like the pharmacy of the patient. And then once it's all filled out, the NP or the PA will review, what's on the intake form and go through all the results of the testing. So that's for the patient side, that they made the phone call, they started getting the ball rolling, and then we kind of take it off in the back end. So we'll start to review the intake. We'll order any testing. So typically if they didn't have a TEE yet, that's the first thing we're going to order. We have the schedulers call them. They get their TEE before they come to clinic. And then I will upload that TEE image, as Sarah pointed out, to the TriClip team on IntelliGrid so that can be reviewed by the reps. So we have a working knowledge of what's going on with the patient even before they come to clinic. Once we get the review from the TriClip team, we'll review that with the implanting IC. And we'll discuss with them their TEE results and what they think about getting heart failure on board early. We do have a robust heart failure program here at St. Francis. So sometimes there are patients who are already seeing heart failure, which is helpful, but those who are not, sometimes we do include them into the plan early. And then we do decide, do they need a right and left heart cath? Some patients are pretty euvolemic that we see, so we may not do it, but most of the time, if they need it, we'll coordinate that to be done after the heart valve center visit, but we have that in mind before they come in. If the patient needs CHF appointment, we'll coordinate that for the patient to be done the same day as when they come in to see us in the valve center. So the patient will get another phone call after their TEE. We'll coordinate their heart valve center appointment, plus or minus CHF appointment, and then we have the heart valve appointment day. Just one caveat to this, if the TriClip case plan comes back saying, probably not the best candidate for a TriClip, maybe TTVR, we're thinking more of a replacement option, then we'll order the CAT scan and the patient will get the CAT scan done on the day of their consultation. And on the day of their heart valve center appointment, they do meet with the IC who's going to do their procedure and with our cardiac surgeon to deem them not a surgical candidate for surgery. So if you don't have a pre-procedure checklist, Abbott makes a wonderful checklist that you can use just to kind of get yourself up and going. Has a lot of information such as the history, like patient history, recent hospitalizations, if they've had imaging done before, and really gives us like a good place where we can take notes and just keep everything in one place. So not to forget, before they come to the clinic, make sure you have plenty of your KCCQ questionnaires. As Sarah mentioned earlier, this is very important to collect data based upon how the patients are filling out their questionnaires. So as you guys know, we're going to get a pre-procedure at their 30-day follow-up and at their 1-year follow-up appointment. And the 6-minute walk test, which we're pretty comfortable with doing when we needed to do it for the mitral clip. The 6-minute walk test is optional for the tricuspid patients, but in our office, we've been doing it just to keep everything consistent. So when we need to contact the patient, we want to make sure that we already reviewed all of their studies, make sure that all the requirements are met. If we need to get authorization for any testing, in our clinic, we do have somebody who does the authorizations, which is extremely helpful. But in other centers, sometimes it has to come from the referring cardiologist. So that part is just really dependent upon your clinic. And then you can consider sending the patient info packet to the patient before they come to clinic. So we also do that too. We model it after how we do our TAVR program, where we will send them a big folder in the mail and it will have information about our valve center. And we do include the Abbott booklet so that they do have some working knowledge of what we're going to be talking about when we see them in clinic. So when we speak with them, we do go over some of this over the phone, and then we give them some expectations, what the clinic day is going to be like. It may be a little bit long, and what kind of testing that they're going to have done, especially if we do end up getting a CAT scan. And we want to make sure we have good follow-up with the patient, make sure that we have their, good contact information, and follow up with the referring as well. Make sure we send them the office note, any testing, and really include them too in the planning process. So when we are going to plan for the procedure, we're going to talk about the peri, post, and information and what we're going to review with the patient. So in our office, we do have a registered nurse who does call the patients and go over all the medications that we're going to stop before the procedure. We explain to them nothing to eat or drink after midnight. And we do that because, the OR or in the cath lab is very dynamic. If a case gets canceled, then we can boost up a patient. We don't want the fasting time to be a problem. And typically in our site, the cath lab is calling the patient for the arrival time. So it's not coming from our valve center, but it is coming from the hospital. And we will explain to the patient, especially during their consultation, what the procedure is going to be like. So they are going to be intubated under general anesthesia with the TEE probe in. And the procedure does typically last between 1 to 3 hours, depending on the comfort level of the IC and depending on the anatomy of the patient. Some patients' anatomy can be more challenging than others. And then post-procedure, just some things to keep in mind. And you can also set this expectation with the patient that they may feel very groggy. They may be in recovery for some hours. They may have a sore throat because they are going to be intubated with that TEE probe in for a bit. They may have some groin discomfort. And typically the patients are staying one night with us and that they're going to go home with all the patient discharge information that they need. So some common questions that we, get in clinic will be like, will I have any pain? Typically there is some discomfort, just like our other transcatheter site procedures of groin discomfort, sore throat, especially if we're intubating or using TEE guidance. Some complications. So the complications are reviewed by the IC and the surgeon when they meet in the office. So of course, bleeding, any vascular complications, but as we went over, the complication profile is very low. What does the TriClip TEER device look like? We do utilize the patient booklet. So we do have some nice pictures for the patient and some heart models in the office so they have an idea of what we're implanting. And some restrictions for when they go home. So mostly we ask them not to drive for 2 weeks. And we ask them not to lift anything heavier than 10 pounds for the first week. Of course, they can take a shower, but we ask them not to submerge their groin in any kind of dirty water, such as a bathtub, a swimming pool, a sauna, a whirlpool. And we ask them not to really exercise or do strenuous exercise for the first week, just to let those groins heal. So this is what the booklet looks like that Abbott has created. It's really a wonderful packet that we give out to the patients. And I really recommend that you follow up with your Abbott rep to make sure you have plenty of these in your office, because it really gives really nice pictures and really lays it out for the patient in a way that they can understand. So once all of our testing is complete and we're ready to book the patient, on our side, something we do is we confirm with the IC who's going to do the procedure on a date that they're looking to do it. Our schedule is pretty busy. We typically do TEER procedures on Monday and Friday. So usually the IC will give us the date, but it's very important to ensure that you have echo available, anesthesia available, and where is this going to take place, either the cath lab or the hybrid OR. And we send out a large email to everybody who's involved in the procedure so that they know who's going, what type of procedure it's going to be done, and where and when. So moving on to the patient journey. So once we get them to the hospital, we do ask them to arrive usually around 2 hours before so we can prep the patient. We prepare the patient for the procedure based upon the PACU protocol. So everybody's place may be a little bit different. Our procedures are performed in the cath lab, but absolutely fine to be performed in the hybrid operating room. And we follow really the post-procedure order sets that we are following for mitral clip. We do it for the tricuspid clip as well. So it's really streamlined the TEER procedures. And the post-procedure recovery and the post-op pathways are really defined by your hospital. And depending if the patient is going to be recovered in a PACU, if the patient's going to an ICU. But the main takeaway is to emphasize groin management. We are using large catheters just to make sure that we're watching the groin, and that we want them to ambulate in 4 hours. And the length of stay is pretty short, It's typically 1 day, and they do get an inpatient DRG for this procedure. So on discharge day, when I go see the patients, I let them know that we have a couple of things to do before they can leave. The first and foremost is the echo. We want to make sure that the clip looks just as good as it did the date before. They get a chest x-ray, they walk with physical therapy. And we really want to make sure that we explain everything to them. We'll provide medications and instructions verbally and written for the patient. So that limits their, the strenuous activity. And, we want them to see their cardiologist in 2 weeks. So if any medication management needs to occur, that they're being seen. And we give our patients a 30-day appointment before they even leave the hospital to try to ensure that we are catching them at that 30-day follow-up period, not only just for the registry, but of course for us to see the patient and get an echo. Another important thing is to make sure that they get their implant card. They will receive a real plastic implant card in the mail, but they'll go home with a paper implant card. And it's important to let them know that they can get an MRI with the TriClip in place. We do get a lot of phone calls in the office if it's possible. So it is on the back of the card that it is an MRI conditional device. So some things you can use for your discharge instructions. This is a great example, not to lift anything heavier than 10 pounds, notifying the clinic if you come back to the hospital. We ask them not to drive until they see their cardiologist, typically in 2 weeks. We want them to start to think about cardiac rehab, really build up their endurance after the procedure. So we talk about that mostly at their 30-day visit. No lotion, creams, or powders to the puncture site. We want them to start walking at home, really start building up that endurance. And like I said, no submerging the groins, any kind of dirty water, so hot tubs, swimming pools, or bath water. We don't want them to stop their antiplatelet medications or blood thinners. So if the patients do have any kind of bleeding at home or any kind of concerns, we do emphasize to call the office. And the dentist is another point of contention. We do try to have them see the dentist beforehand if they have any outstanding dental work. If they can't, we would like them to wait to see the dentist for at least 6 months and understand that they do need to take antibiotics after the procedure when they go to the dentist. And then if the patient is hospitalized, like I said, anywhere, it may not even be in our institution, but if they are, that they should call and let us know. So, okay, so we're at the follow-up. So it's very important to build a very strong pathway for your follow-up process because the patient volume is going to grow and we really need to keep on top of all of the patients and organize in an organized way. So I like to use Excel. I think it's an easy and very clean, concise way to keep the patients listed. I put the date of service, who went that day, their birthday, and their follow-up appointments. And I can always use that Excel sheet for their 30-day and then again for the 1 year. So it's user dependent. If you like paper charts, that's wonderful. If you like Excel sheets or a cloud-based system, that's also great. But really the most organized way that you're going to keep the patients is best. Also, just to point out to document no-show appointments, it is important for the registry that we do at least try to contact the patient at least 3 times for the follow-up. So if they don't show up to the office and we can't reach them on the phone, it is important to document that. So just like the pre-checklist, Abbott has a really great follow-up checklist where you can keep with the patient's information, the 30-day and the 1 year. So you want to make sure that we're hitting all those points to put into the registry, which we'll talk about. So the 1 week follow-up is optional. We do like to call the patients, just make sure that they're doing okay at home and just review that, their medications. The 30-day and the 1 year are required. And it is required by the TVT registry to see them between 23 and 75 days post-procedure. And then for the 1-year follow-up, we have a range of 305 days to 425 days post-procedure. And for the follow-up appointments, we do ask them to bring a current list of medications. Sometimes the cardiologist makes some changes after the procedure, or if they have heart failure that's very involved, they sometimes will try to titrate down off their diuretics. During their visit, we'll do the KCCQ, of course, the 6-minute walk test, an EKG, and an echo. We don't typically do labs, but if they need labs, we can do that as well during their visit. And then, we call them, like I said, after the procedure, and, if the patient needs any kind of transportation assistance, we can try to move the follow-up around just to try to help them if they have people that need to take off from work to bring them to the office. So championing your program. So, the heart team has everybody around the patient has such a direct impact on the patient care. However, the coordinator is with them from that first phone call, from that first intake, all the way through the procedure, all the way through the 30 days at home, and then even to the 1 year. So the valve coordinator and the patient really are like best friends during this process, and everybody else plays an integral role, but really we build that strong relationship with the patient. And you really want to make sure that your clinic is easily accessible and is easy to be found online. So we want to make sure that referrings can find where they can send patients to have their patients treated. And sometimes patients also will look online to see where they can be treated. We've had a couple of patients find us on their very own. So, just some ways that you can get your clinic out there. Abbott does have the Structural Heart Clinic Finder, so it is a very valuable and useful resource if you do need that extra help of outreach. And the same about tracking the patient. So how are you going to track your patients? There's the EMR system. So if you have Epic, that can be helpful. They have a structural heart tab. Or if you have a cloud-based where people can share the document. Personally, I do like the Excel option on a spreadsheet. I think it's a very clean way of keeping track of the patients, the referrings, their visit appointments. You can have lots of different data on each sheet. And the whiteboard, sometimes a whiteboard is very helpful, but when your volume starts to grow, you're going to end up running out of space on your board. So maybe one of these other systems is a bit better to just track the patients. And ultimately, as the coordinator, we really have to advocate for our program and for our patients. With new therapies, we need to identify the stakeholders in our institution who's going to help onboard this therapy with us. Perhaps with this influx of patients, you're going to need more staff, more office time, more supplies, a different block of time in the cath lab or the hybrid room. And really identifying your stakeholder is going to be really paramount in moving the program forward. And with doing that, you have to conduct periodically review of yourself and your program. Like, what are things that are working really great? And what are some things we can really improve on? And knowing the financial aspect of the procedure is also very important. I know we're healthcare providers, but the hospital is here also for a business aspect. So it's very important to build that relationship with your finance team. And with tracking the patient, you can also start to track that halo effect. Like Sarah said, we're sending patients to heart failure, we're sending them to EP, we're getting different kinds of testing on the patient. So the halo effect's quite large for the financial portion. So it's really important to be able to advocate that to the stakeholder as to why you need more resources to really get your program up and running. And then we want to really highlight the successes. So patient stories, screensavers on the computer, different kind of news articles that we can put out to really emphasize and highlight what our clinic is doing really will set your program aside from others. And as we all know, we are the heart of our programs. We wear so many hats. We're the first phone call that the patient has, that the referring has. We are triaging clinical complaints. We're communicating with the referring. And, it's a very, very hectic and, lots of different things going on job, but it's extremely rewarding. And it's a wonderful opportunity that we have to make such a great impact on so many people's lives. So just a little bit about the TVT registry. I know we're coordinators for, TAVR and mitral clip. So this isn't something that's not particularly new, but it is very important. So the functions of the TVT registry is to really obtain data from different hospitals and to create a very large data set to get the quality information and to create risk models. It also fulfills the NCD, or the National Coverage Determination requirement from CMS, that we must participate in a registry. The registry, the data also can be accumulated for post-marketing device reporting through the FDA, so they can gather trends within the data to see, if something seems skewed, they can deep dive into that. And it really generates lots of evidence, and it does help create research and provide critical information for future decisions, whether, for any kind of data that they want to pull from the registry, they're able to help with creating future recommendations. So the public reporting, I'm sure many of us are aware, but it did roll out in 2021-2022 year. It is different from the US World News and Report ranking. So it does have a special feature where you can opt in between February and March to publicly report. So if you make that decision that, yes, I want to publicly report our data for our clinic, you receive a draft data, well, everybody does, in June and July. And then at that point, you can reconsider your early decision. So if you wanted to initially say, I want to opt in and share and publicly report my data, and then in June, July, you actually get your data and you say, you know what, maybe we'll sit this one out. You are allowed to opt out if you would like. However, you cannot do it in reverse. So if you initially decide that you do not want to publicly report, and then you get fantastic results in that June, July drafted data, you cannot opt in at that time. So that is something to consider. And one of the requirements is that you must have greater than 90% of your KCCQ that's done at the baseline. So one other thing about the stars is that your star rating is based upon quality measures, not based upon your volume. So they look at 5 quality measures, such as mortality, stroke, major bleeds, AKI, and if the patient has moderate or severe PVL, of course, for the replacement portion. So those are the quality measures that are looked at 30 days in order for them to compile a score. And then your score is plotted on a whisker plot chart, and then they decide if your star is based upon that. So even if your site doesn't do 500 cases a year, if you do 100 cases a year, your 3 stars are equal to a program who's doing a lot more volume. So some things just to consider with the registry is that to just make sure that the data is entered completely and in a timely fashion. You can work with the registry if you have any questions or any missing data. They're actually very wonderful to talk to. So if you have any questions, they're very, very helpful. Make sure you get your patient engaged, scheduling the 30-day and 1-year visit, and track the patients. Make sure you're capturing as many as you can. And then the critical elements, of course, is that KCCQ questionnaire, which if the patient cannot come to the office, you can always do it over the phone. and then the pre and post-procedure echo variables. That's really what the data is looking for to see the reduction in the tricuspid regurgitation and for all the patients. So with that, I'd love to really thank Abbott for sponsoring this tonight and thank my partner, Sarah, for her presentation. This has been really a wonderful evening.
Thank you so much, Lindsay, for a great presentation, really a very thorough review of the patient journey. And thank you so much for covering the details of what a patient goes through from soup to nuts, as it's important for all of us to hear that and know that. And Sarah, you as well. Thank you so much for a very thorough discussion and going through all of the points of care that you did as well. So I'd like to move to some questions now, if that's okay with you guys. And I'll let you guys take the lead on answering these. I think looks like Sarah's already answered some of these questions. So I'll just toggle through and see what hasn't been answered, and we can go from there. There was a question, I want to review this because I think it was an important question. And it was about whether you guys are having heart failure doctors see your patients, and Sarah had said that they don't routinely have them get involved. How about you, Lindsay? Do you, at your site, do you typically have them get involved right at the beginning or ever?
So yeah, that's a great question. So we do have a lot of patients who already see heart failure or are being treated with heart failure regimens, which in that case, we don't re-refer, or we won't step on the referring's toes if they're being managed properly for their heart failure. If they look very overloaded in the office, if their PA pressures are very high, if their RV is down and we're very concerned, we will send them to heart failure. And we do try to, like I said, we do try to coordinate that for the patient so they only have to come to the campus one time. So we do try to make that decision a little bit ahead of time before we see them.
So I think the flavor of the question was more, is that mandated as part of your programs? And it sounds like from both of you, it's not mandated, but that you take it on a case-by-case basis, whether you involve them or not. I think that's a perfectly fine way to do it. And actually, I'm going to be a little selfish, and there was a question actually from my former valve coordinator, Jennifer Docampo. Hi, Jen. Thanks for being on the call. She's asking, is everyone only doing straight Medicare, or has anyone had luck with private insurances as well? How about you guys?
Yeah, we are doing mostly Medicare, I would say, but we have had some private insurers. And we have had just, I think on Monday, had to do a peer-to-peer, but we were able to get it through, no problem.
Okay, and what are you guys doing with Medicare patients? Yes, no?
Yes.
Yes, okay, all of them, yes. You too, Lindsay, Medicare patients?
Yes, we have
routinely?
a large Medicare population, but we do also have a lot of Advantage plans that we deal with. And those do sometimes require peer-to-peers, which we've been successful to get authorized. We do have one company that has given us some trouble, but ultimately we've gotten it approved.
Okay, so we have another question here about right heart caths. Are you guys routinely doing it on every patient or selected patients? And are you repeating them once you have the initial information? I think Sarah answered that they don't necessarily repeat them. And while they don't get them on everybody at her institute, they do seem to get it on a lot of patients. It was part of the trial to get them on the patients, but commercial patients, obviously, you don't have to. Is that, Lindsay, is that what you guys are doing at your site?
So not all of our patients are getting right heart caths before a TEER procedure. Typically, we have been doing it before every single TTVR procedure. We've noticed that a lot of the heart failure doctors like to use the right heart cath to help guide management. So, if we're not going to re-refer them to heart failure, sometimes we will not do the right heart cath. Okay,
thank you. Is this a very interesting question here that was posed by Michaela Pape. I hope I'm not mispronouncing that spelling. Michaela asks, for patients that are not candidates for TriClip due to a large gap and annular size, have your physicians done bicameral clipping essentially to prep them for TTVR. Is that something that you've encountered at your let's let Sarah go first. Sarah, have you encountered that at your institution?
I can think of some cases where we have had to consider tricuspid valve replacement after TriClip due to annulus size and anatomy. Absolutely. I can't say that I've had an example yet where we've done it to prepare a patient for a tricuspid valve replacement, but that would be interesting to see.
How about you, Lindsay?
We've had a few cases where we did attempt on a very large annulus, a TEER procedure in which we had to abort. We couldn't grasp the leaflets, and then we did work the patient up for TTVR, which was successful. We have not done a TEER before replacement in that staged fashion before, no.
Okay, here's another good question. And I'm sorry, the chat's cutting off some of the Marcus Burns. Okay, this question is essentially, what do you do with people who need tricuspid valve? Let's see, approaches to tricuspid TR. So patients who have had clipping now have recurrent TR. How are you approaching these patients? Are you bringing them back for repeat TEER? What's the practice, or have you had many of these patients?
Yeah.
Sarah, you can go first.
Optimizing medical therapy first, finding diuretics. If we feel like we got them euvolemic before and their kidney function could tolerate it, and then we see them back in the office at 30 days and their TR is back, it may be worth bringing them back in for a right heart cath to see what those pressures look like, see if we need a change in diuretics, engaging heart failure team, or the option of a repeat clip is always there.
How about you, Lindsay? What are you doing at your institution?
Yes, very similar to Sarah. We'll bring them back to the office. We'd likely get another TEE to see exactly where the leak is happening. Maybe this is a new leak that we didn't see before, or the patient just developed. Really maximize their diuretic therapy. At that point, we would probably also have heart failure involved. And we haven't brought a patient back yet for a repeat TriClip, but we do it with the mitral side. So there's really no reason why we wouldn't do it for a tricuspid.
Okay, thank you. I'll just what I'll do is, in the interest of time, I'll pose a question to each of you back and forth. That way we can try to get these questions answered, because they're very important, and we've got so many folks who are interested in what you have to say. I want to make sure we look at as many of these questions as we're able to. There was a question about post-procedural antiplatelet / anticoagulation therapy. Sarah, since you already answered that, do you mind sharing your answer with the team here?
Sure, we do aspirin alone, just like MitraClip, unless they're on a pre-op regimen like Plavix for something else, or anticoagulation for a different comorbidity. We just do single antiplatelet monotherapy with aspirin.
Okay, and this one's for you, Lindsay. Is pre-dental antibiotic needed at your institution for just 6 months post-TriClip or lifelong?
So before the procedure, the patient doesn't need any dental prophylaxis, but after the procedure, we would like it to be lifelong. Sometimes the dentist will, give the patient some pushback that after 2 or 3 years, it's sufficient, but our recommendation is for lifelong antibiotics before the dentist.
Okay, this is a very quick question. Who charges for the visit, follow-up visit, or pre-procedure follow-up, yourself or the doctor? Sarah, why don't you take that one?
Whoever sees the patient charges. Initial consult's usually done by the physician here, and they charge, and then everything else is usually by the APP.
Okay, fantastic. That was a quick and easy one. Is a question, Lindsay, you take this one. Is a 6-minute walk required for TriClip at your institution? Yeah, what are your thoughts on that?
Yeah, so it's not required to be done, but we do use the PI department actually does all of our data abstracts for the TVT registry. They did send us many emails in the beginning, like, where's a 6-minute walk test? They seem to want it included in their registry, so data. So we've been doing it for everybody pre and post.
Okay, fantastic. Well, I think that's a good thing to do, because that's how the trial was done. And I think it gives if nothing more, it tells the patient, or it gives the patient 2 points in time to let them know that they really did improve, right? So as a question, again, a lot of questions about insurance. So that's interesting for Abbott to know about, actually. I think we probably need to do a better job of getting this out there. Besides peer-to-peer, what other tips do you have for getting this approved? Sarah, any tips and tricks that you guys are using down there?
We've had to print out some articles regarding surgical risk and mortality regarding to isolated tricuspid valve replacement. That's helped submitting that data, and then having multiple doctors' opinions of why this is high risk and why the only approach is transcatheter is always helpful.
Yeah. Well, I think, and what's also sometimes helpful is to yell and scream on the phone and tell them that they're really harming the patient, which is sometimes what I used to do. It never worked, by the way. So probably not a good strategy. Let's see. Next question. Are there mechanisms causing TR, like severe pulmonary hypertension, where TEER may not be considered? Lindsay, what are your thoughts on patients who have severe pulmonary hypertension? How do you approach that patient from a pre-procedural evaluation to determine if they can or cannot be done? Or
Sure.
should not be done, I guess,
Yeah,
is a
so
better
a
way
lot
to
of
ask.
the patients who are presenting already with severe pulmonary hypertension, that's one of the types of patients we would get heart failure involved in, and we would do a right cath to see how severe it is. Do they need to be treated or be put on treatment? We have done TEER on patients who do have pulmonary hypertension, that the RV is still not totally down, and we feel that it's safe to do, but we really do take heart failures input because they typically are the ones treating it, and they have a good idea of how significant it is and if we're going to get any benefit from doing our procedure.
Yeah, I think that's a great answer. One of the things you can also do is, oftentimes these patients have combined pulmonary arteriolar, or as well as pulmonary venous hypertension. And if you know that that's something you need to answer, whether it's fixed pulmonary hypertension or reversible to some degree, is if you know that before the right heart cath is done, they can do some provocative things during that procedure to determine what is the nature of the pulmonary hypertension. And what we used to do is get our we actually had our center had pulmonary hypertension specialists who happened to be pulmonologists, and that's kind of all they did. They pulmonary hypertension. We often would get them involved in addition to the heart failure physicians to answer questions of those type. And those are oftentimes the sickest and most complex patients. Another question here, patient that has severe TR and severe MR, what do you do first? I can tell you what they did in the trial first, and then you guys can answer. In the trial, it was required that their left heart disease be addressed first before TEER. I suspect that's what most people are doing, but Sarah, why don't you take this one? And Lindsay, on this one, I'd like to hear from you as well.
Yeah, we do the same thing. We usually address the left-sided heart valve problem first, and then bring them back at 30 days, see what that tricuspid valve is doing. But it is important when you're thinking about that to look at the actual pathophysiology of why the tricuspid valve is leaking. Is it functional? Is it degenerative? And then go from there. But we usually do a stepwise approach like the trial.
How about you, Lindsay?
Yes, we also fix left heart valves first. So we go in an order of aortic, mitral, and then tricuspid. If the patient does have if we think the pacemaker lead is impinging on the TR, we'll send them to EP as well, just to get that looked at to see if they need a laser lead extraction or something to that effect while fixing the left side first.
Okay, so a couple more questions. Let's do quick hits on this. I think we've kind of already covered this, but I'm just really amazed at how many insurance questions there are. Looks like they have this site. This question, by the way, is from Julie Garibay. And again, my apologies if I mispronounce the name. They have quite a few insurances refusing to give authorization because CPT code is temporary. Is there a workaround? Sarah, what are you doing for these workarounds? You kind of already told us this, but anything else you want to add to that?
I think that's all I've got.
Okay.
Let's see if you have anything to add.
Lindsay, you have anything to add?
Not really. We don't really have too many workarounds for the CPT codes. Kind of those are the codes that we're using right now. So
Okay,
it
so
can
I
be
think we've
challenging.
covered the insurance part. Let me just make sure there's no other questions. Like other Abbott team members, if you see questions which I haven't asked about, there's more insurance questions, but I think we've kind of answered those in one way or another already. There's a question. There was some sort of an MRA explanation that was given by Sarah. Can you reiterate that? Someone missed that part of it. Maybe just a very 3-line summary.
Yeah, it's a diuretic, aldosterone or a aldosterone antagonist. Sorry, end of the day. So it's just going to help the heart, help get fluid off the body, potassium sparing. So it's one we like to put in addition to our Bumex or torsemide to get more effectiveness with fluid removal.
Wow, I completely misinterpreted that question. I thought they were talking about some kind of an MRA, like an imaging study. You're talking about mineralocorticoid receptor antagonists. Okay. Okay. Well,
I think that's what
I'm
the
glad
question
you
was.
picked up on that question. Well, thank you. Okay. I think we hit most of the questions, if not all. I think we got them all. Yeah. Let me just flip through. I want to make sure I didn't miss any. And if anyone's still on the line, we're willing to stay back if you have any questions that you want to ask. Oh, there was a question about volumes at your institution. How many TriClips are you doing, Lindsay, at St. Francis?
Since last year, we did almost a little bit over 40.
A little over 40. How about you, Sarah?
We're about half that. We're about 25, 30.
Okay, that's still a very good number. I do believe we have successfully covered all the questions. With that, I want to thank everybody for joining this session. It was very informative, including for myself. I'm learning new things every time I join one of these, so it's helpful for all of us as a community to hear from each other, particularly folks like Lindsay and Sarah, who were really at the top institutions in the country, not just in terms of volume, but in terms of the quality of work that's being done there, particularly at both of these institutions. As I said, I have personal experience with Norfolk, with Deepak Talreja that's there, Dr. Summers, and before that, Dr. Mahoney, and of course, Lindsay at your institution. I know Jafar Khan personally, and you guys have other great, Omar, other great physicians that are doing great work there. So thank you so much for sharing your insights. Thank you to the Abbott team, Kara, Nikki, Amy Ann. If I'm forgetting someone, I apologize. You know, these folks really do a lot of hard work behind the scenes to get these webinars out to the community. So kudos to them and thanks to them. And with that, I will bid you farewell. Thank you all for joining, and we look forward to seeing you at the next one.